Good evening, everyone. I'm Saranjeev Rangaraj. I'm a PhD scholar from the Department of Biochemistry, University of Hyderabad. And also, I'm a PMRF fellow. To fulfill my teaching assistantship hours, I have been associated with this NPTEL. And the course that we have been seeing for the last 11 weeks, that is overview and integration of cellular metabolism. And we are in the last week, that is week 12. So, as usual, we'll get into the agenda for the day. We'll recap on the 12th week concepts. Then we'll do some practice question, and if you have any doubt, we will go for the doubt clearing session. So far we have seen all the metabolism that we have started with the carbohydrate, lipid, protein, specifically amino acid metabolism that we have seen, and finally we have ended with nucleic acids. And most of the cases that we have always associated, like seen the disorders related to the specific metabolism and what are the regulation that we have seen. So today we are going to see with certain diseases as well as our habit in the day-to-day life, how it is going to affect us. The first disease that we are going to see is diabetes mellitus, and which is almost similar to starvation. The reason is, even though the adequate glucose is there in the body, which cannot be sensed by the cells, then it reaches the state called the starvation state, and that led to the hyperglycemic state. So that we are going to see step by step how it is going to happen. So in a normal state, what it should happen, if any glucose is there in the body or after a meal, the beta cells of the pancreas should secrete the insulin in a regulated fashion. Then it will work on certain organs. For instance, liver in this case, it will increase the glucose uptake, and then they increase the glycogen storage in terms of the glycogen synthesis, and then it will promote the glucose metabolism to the fatty acids by forming the triacylglycerol and then the VLDL, and it will inhibit the gluconeogenesis and then the glycogenolysis in any normal state. In the same way, in the skeletal muscle, it will increase the glucose uptake and then the glycogen storage and then the new protein synthesis, and the protein catabolism will be inhibited. The same takes place in the adipose tissue, where through the GLUT4 transporters, the lipolysis will be inhibited through hormone sensitive lipase, and then the glucose uptake will be increased, and finally the fatty acid uptake, where the lipoprotein also will be stimulated. But in terms of the diabetes mellitus case, what will happen? There is such kind of insulin resistance takes place. So insulin resistance means there will not be a even though the enough insulin is produced in the body, the receptors that is responsible for the insulin is not responsible. So that leads to the multiple levels. For example, in any case, for liver, if you take it, the gluconeogenesis will be synthesized. The reason is the cellular level of like glucose is very less. So the gluconeogenesis will be stimulated, and then the glycogenolysis will be stimulated to increase the glucose in the body, and that leads to the hyperglycemic state. The same way, the increased levels of the glucagon and then the epinephrine in the body, that leads to the glucose uptake reduced, and that also finally increase the hypoglycemic state. In muscles, if you see, the protein degradation will be increased. The increased protein degradation leads to muscle wasting, so that leads to the weight loss. And this protein degradation will give the amino acids. So this amino acids, again, it will be converted to uh, intermediate of the TCA cycle, and finally it can go to the gluconeogenesis. And in adipose tissue, due to the insulin resistance, it increases the lipolysis, and then the acetyl CoA level will be increased, and that leads to the ketone production in the ketone body production in the body, that results in the ketoacidosis. And the same way, when the insulin is not sensed by the cells, so the lipoprotein lipase activity will be reduced. That leads to the high level of the chylomicron and the VLDL. Then the circulating triacylglycerol levels are upregulated, so that results in the hypertriglyceridemia. So this is what the diabetes mellitus state. So whatever the things that we have seen it in the last slide, that will be reversed. And finally, there are three or four symptom states place. There is a hyperglycemic state in the body. Then the muscle wasting will be takes place, and ketoacidosis. That is why then the diabetes mellitus patients that we get the that acid smell whenever they are burping or they are after they use the restroom also, that we get such kind of acid smell, that is because of the ketone body production. And next one is during the trauma. So trauma state can be anything that you are traumatized by any kind of accident or by any kind of event, like you are traumatized by your exam fear. So many things will be there. Here that we are talking about the trauma happening in during the accident case. So what will happen whenever any kind of the stressor or the trauma surgery infection takes place, that leads to the epinephrine norepinephrine sympathetic drive, and it can also produce a certain kind of cytokines which switch to the T cell phenotype inflammatory mediators. So that leads to the uncontrolled catabolism and then the resistance to the anabolic signals. Finally, the uncontrolled catabolism leads to the energy expenditure and then the substrate use. So this can be due to the multiple reasons. For example, the cortisol synthesized by the body, or epinephrine, or norepinephrine, or glucagon, and the growth hormones levels are increased. So that also results in the cytokine release in the excessive amount. And during the traumatic stage, the oxygen and then the energy requirements increases in the body, that always proportional or the directly proportional to the severity of the trauma. In this case, the free fatty acids, whatever in the body, that can be used as the energy source, and then the triglycerides meet around the 50 to 80 percentage of the consumed energy, and it also increases the proteolysis in the body. It also increases the protein degradation in the body. So we can separate any kind of trauma, in this case that we are talking about the any kind of injury, into three phases. First one is it kind of called as a EBB phase. So that is around it's called shock phase. That is from 24 to 48 hours of shock. And after that we can say some several days, that is 2 to 7 days, that is called as a catabolic phase. And finally after several weeks it can be called as a anabolism phase, that is nothing but the recovery phase. So we'll see one by one what is going to happen. In the shock phase, that is within 24 to 48 hours of the injury, the decrease in the total body energy expenditure takes place and urinary nitrogen excretion takes place, that leads to the stress hormones levels increase. The second phase is nothing but called the catabolic phase, that happens for 2 to 7 days in the body. In this phase only, the increased oxygen consumption takes place and then the increased metabolic rate. The reason here is this create a situation called the reduced glucose utilization, but with an increased utilization of the triacylglycerols as well as the free fatty acid breakdown. And already we have seen in the last slide, the proteolysis will take place, that leads to the muscle wasting. Then third phase is called anabolic state, which is reached by the 3 to 8 days, or we will take several weeks after 1 week. Uh, which leads to the positive nitrogen balance in the body. Here the negative nitrogen balance will take place. That ensures the increased protein synthesis in the body. And then the rapid and then the progressive increase of the weight and then the muscle force will take place once after the surgery. And related to trauma, if you see the change in the lipid metabolism is the free fatty acids are released from the triacylglycerol, that primary source of the energy after trauma, and then the lipolysis is accelerated in the early period because of the increased ACTH, cortisol, catecholamine, glucagon, growth hormone, and then the insulin levels. And the protein metabolism, usually the negative nitrogen balance takes place in the early phase, and finally it leads to the positive nitrogen balance in the body. And changes in the carbohydrate metabolism we can see that leads to the hepatic glycogen storage is depleted initially, that is 12 to 14 hours of the post traumatic event, and the gluconeogenesis is driven by the stress hormones and then the cytokines. So usually people will do the administration of the glucose during the fasting stage and then exogenous insulin therapy. So till here we have seen most of the thing that we have started with starvation in the last week, and we have gone through the what is diabetes mellitus, and now we have seen the trauma. In the upcoming slides, we will see about the nutritional disorders in after 2 or 3 topics later. So the next topic is metabolic control analysis. So here we want to see there are different terminology used in the metabolism that has different meaning, but people might use it in the same way. So that's why that this slide we kept. So first one is the rate and then the flux. Rate and flux are two different things. Rate is related to a one enzyme in the particular pathway, whereas flux is used for the whole metabolic pathway. So we can say that this flux term is used in the metabolic analysis to indicate the rate of multiple component of the system. For example, we can say the whole glycolysis that we are talking. What is the energy flux? Flux. Whereas in the rate, in the sense that we will talk about the one individual component or the enzyme. For example, here we can say what is the hexokinase rate. So how much substrate that I'm giving, how much the product is formed. By measuring this, we can say that what is the rate of the reaction or the rate of the enzyme. The second one is a regulation and control. Control is nothing but which is a start and stop cycle. Once the control is, you can start it or you can stop it. Whereas regulation is something different. There are certain variables are included in that thing. For example, the temperature or the concentration of the substrate or the fluctuation in the external condition. So that leads to the regulation of the body in a temporary case. And finally, the metabolic control, the power to change the state of the metabolism in response to the external signal. So this is always measurable in terms of the strength of the metabolic response to the external factors without any assumption about the function, purpose, and mechanism of the response. So we always know that in the conventional concept, in any kind of pathway that we say the single rate limiting step, but that is not the correct way of measuring any kind of metabolic pathway. That's why people have started with the uh, idea that what is the metabolic flux in the body or in the any kind of pathway or the whole pathway related. So that's where the control of the flux is distributed among the several enzymes. So that is, if the 10 enzymes are there together, 10 enzyme activity on the pathway that we are going to see. And this control varies with the metabolic circumstance. For example, the supply of the starting material, the supply of oxygen, the need for the other products derived from the intermediates of the pathway, the effect of the metabolites with the regulatory tools, or the hormonal status of the organism. So this helps us to understand the whole metabolic flux. It helps us to understand the action of the certain hormones and then the drugs on the metabolic pathway, to study the pathogenesis of the metabolic defects, and then to develop the drug that stimulates or inhibits the pathway, and then the commercial bioengineering also it leads with this. So to measure the metabolic flux in the body, we or any kind of pathway related to any kind of pathway, we will go for three different kind of measurement. Before that, I will explain this one to explain what is the glycolytic flux. So here people have taken the three different enzymes of glycolytic pathway that people they have taken it from the rat liver, and then that homogeneous rat liver they used to isolate these three enzymes, and they have given it to the cell to see the what is the rate of glycolysis takes place. If you see, whenever the hexokinase 4 is added in the system around from 0 to 3.0 units, the glycolytic flux is increased. Whereas when you have added the phosphoisoisomerase, the glycolytic index is not changed. In the same way, the phosphofructokinase, whenever you add it, that is in the same level, it is not increasing beyond a certain point. So this tells that there is a such kind of flux between the pathway. There are certain enzymes can be regulated. Certain enzymes will be really helpful in the whole glycolytic flux. That is what this says, that the hexokinase 4 that uses in the rate of the glycolysis that progressively increased, whereas purified PFK1 not as dramatically as did the hexokinase. So here we can talk about the control, and whereas purified phosphatohexose isomerase, which is having the no effect in the glycolytic flux, because the enzyme hexokinase and then the phosphofructokinase is not active in the system. So we are going to see the three parameters, how those things are related to the flux control coefficient, or the flux metabolic flux. Here the first one is the flux control coefficient. This deals with the metabolites uh, that are formed during the metabolic pathway function. So this is called as a flux control coefficient, that is C. The flux control coefficient can have any value from the 0 to 1, so the main determinant of the flux, or it can have the negative control also. The negative control people usually seen it in the branched pathway. So for example, A to B conversion is there, B to C conversion is there, and then C to D conversion is there. But B is the really responsible for formation of C and formation of E, if you see. So the increased this X enzyme here, that is involved in the B to E conversion, there is a negative impact here. So that leads to the C value negative, whereas here in the positive term. And the flux control coefficient of an enzyme is a system property, not an enzyme in the isolation property. So if you say there are three enzymes involved here, that is X0 to Y, that is Xase, Y2 is that is YDH, and then the Z2 is Z1, that is ZDase. So these all together, whatever the metabolic flux is there, the coefficient, whatever we are talking about C, that is the combination of all three, not a different enzyme. So that is what I am trying to say. C is not an intrinsic to a single enzyme, rather than it's a function of the whole system. And this usually depends on the concentration of the substrates as well as the effectors. And the metabolic effect on this coefficient C, if you see, effect of the metabolites tends to counteract the change in the amount of the enzyme. That seven enzymes will share the control over the flux. So that also can change the flux control coefficient C. The next one is the elasticity coefficient, that is E. So this is it deals with the single enzyme that we usually say in the metabolic pathway. So we usually know that what is equation, that is Michaelis-Menten equation. Over the period of time, the increased substrate concentration leads to the saturation of the all active sites in the enzyme. So that leads to the less elasticity of the enzyme, whereas when the active sites are not occupied with the substrate, then we can say that that is having high elasticity. So here you can see the elasticity is almost 1, and here the elasticity is almost 0, because all the uh, active site related to the enzymes are occupied here. On the last coefficient, if you see in this thing, that is a response coefficient, that is R. So this is not related to either the flux of the pathway or the nor the enzyme. This is related to the quantitative expression of the relative impact of the outside factor, such as hormone or the growth factor, how that is implementing or the impacting the any metabolic pathway. So this responsiveness of a pathway to an outside factor that affects a certain enzymes is a function of the sensitivity of the pathway to the activity of the enzyme that is target for the effector, that is flux control coefficient C. The strength of the effect of the P on the enzyme, the how sensitive that specific enzyme is to changes in the outside the controlling factor, the elasticity E. And this responsive coefficient can be examined each enzyme in the pathway, and then effects of the several effectors on the flux through the pathway can be separately determined. The pattern of the change of flux of substrate through a series of enzymatic steps can be predicted when there is a change in one or more controlling factors that is external to the pathway. And the next topic is the obesity. So obesity is usually leads to the excess calorie intake or the storage in comparison to its expense by the body energy or the consuming activity. This can handle an excess of dietary calories through the following mechanism. The first one is the conversion of the excess fuel to fat and storage in the adipose tissue, and then the burning excess fuel through the additional exercise or the physical activity, or the wasting fuel by diverting it to the heat production through the uncoupling and thermogenesis. So, if you see, the best way to see whether the one person is obese or not, that we usually use the index called body mass index. So that is calculated by weight in kilogram by the height square in meter. So that tells that if any person is an underweight, that is their BMI is less than or equal to 8.5. If they are normal, that will be considered as 8.5 to 18.5 to 24.9, and the overweight is considered as 25 to 29, and then the obese person is called between 30 to 34.9. So the grade 1 obesity is called 30 to 34.9, and grade 2 is 35 to 39.9, and highly obese people called more than 40. Usually, this BMI is an indirect measure of the obesity, and individuals with a high proportion of muscle mass can have a higher BMI. So, any bodybuilder who is going to for the muscle development, they will have more protein than the fat. So that time we cannot say they are obese. So that's why there is another studies also we can see how they are going to be helpful here. There are other studies like that we can do the skin fold thickness test or bioelectrical impedance or underwater weighing or inconvenient. These things are inconvenient as well as the costly. So that's why people will usually go for the waist circumference test. So that will tell that if it is a more lipid accumulation is there, so that leads to the obesity. So why waist circumference we usually see? There are two different fat in the body. One is the subcutaneous fat that is under the skin, and second one is the visceral fat that we have already discussed during our fatty acid metabolism. So if you see the under the skin, whenever the visceral fat is level is like increased, so that leads to the tummy kind of shape. This increased tummy will come, and then that leads to the increased risk. So that is what we are going to see now. The first one is the fat stored is just under the skin, and then it is not and which constitutes the 80 to 90% of the total fat in the body. Whereas in the visceral fat, which is composed of the omental and then the mesenteric fat present in the close association with the digestive tract. And this excess of visceral fat is more strongly related to the metabolic risk factor when you compare with subcutaneous fat. And there are two different fat that we say, that is abdominal fat that usually seen in male, and then the gluteal fat that is seen in the female. So this is smaller in cell, and then the gluteal fat is in the larger cells, and this is more responsive to the hormones, both visceral as well as in the subcutaneous fat. But this gluteal fat is less responsive to hormones and release of the substances via the portal vein and then to liver. But here the release substances to circulation with no effect on the liver. And if you see the risk factor that is related to, or those factors related to develop obesity, that is poor diet, where we are taking more caloric food like the fat diets or the high glucose diet, those kind of things. And then the sedentary lifestyle, that is the lack of the physical activity, genetic factors, and then the environmental factors as well as the socioeconomic factors. And there are psychological factors also related to the obesity. And if you are deprived of sleep, and that leads to the poor sleep pattern, and then that disturbs in the hormonal regulation, and it affects the appetite, and then increase the risk of the weight gain. And then the medical conditions, certain medical conditions like hypothyroidism, polycystic ovarian syndrome, and some medication can contribute to the weight gain and as well as in the obesity. And there are certain hormones, these things are responsible for this fat deposition as well as the fat degradation in the body. In this lecture that we are going to see three adipokines that are synthesized by the adipose tissue. For example, the leptin, adiponectin, as well as the resistin that we are going to see. And this helps in the homeostasis and then the metabolic status of the body, inflammation as well as in the obesity cases. The first one is a leptin. So leptin is synthesized by adipokine, adipose tissue, where it is first identified as the product of the gene that is in obese patients, and it is around 167 amino acids in the body, in size. So what usually people understood so far from adipose tissue, this leptin secreted and that transported through hypothalamus via the leptin, and then in the arcuate nucleus this leptin induce certain genes that leads to the neuronal signal via the sympathetic neuron, and finally it comes to the adipose tissue where this norepinephrine is synthesized by here, synthesized from hypothalamus, that binds to the beta 3 adrenergic receptor that leads to more GPCR signaling, and finally it leads to the uncoupling of the beta oxidation, and finally it leads to the heat dissipation in this body. So that's what overall people have seen. This is through the JAK-STAT pathway. So whenever the leptin is there in the body, this ligand is goes and binds to the receptor monomer called JAK. So whenever it binds, then it will become dimerized. After the dimerization happens, the JAK pathway, whatever it is there, it will be phosphorylated by the kinase that is called Janus kinase. Once this Janus kinase phosphorylate this too, then the STAT binds here. That is, this is called signal transducers and then the activators of transcription. Then once it binds to the phosphorylated signal, then that itself again dimerized. Then it will go into the cytosol, from the cytosol to the nucleus of the host. Then it will increase the mRNA levels of that POMC or the neuropeptide. So this again increases the norepinephrine levels, and which acts through the beta 3 receptors, and finally stimulation of this UCP happens in adipose tissue, and there in the mitochondrial uncoupling takes place due to this UCP1 increased levels, and that leads to the increased catabolism of the fat as well as the thermogenesis. And if you see in the starvation state, the reduction in the leptin levels are triggered because we have to take more food, and then the nutritional deficiency and reverse the thermogenic processes allowing the fuel conservation. And leptin triggers the decreased production of the thyroid stimulating hormone, slowing the basal metabolism, and decreased LH as well as the FH, preventing the reproduction. An increased production of glucocorticoids takes place, that is mobilizing the body's fuel generating resources by minimizing the energy expenditure and maximizing the use of the endogenous reserve of energy combine the severe nutritional deprivation. And in liver, muscle, leptin stimulates the AMP activated protein kinase and favoring the energy producing process. And if you see, leptin increases the insulin sensitivity because they have some crosstalk leptin as well as insulin. So that leads to the fatty acid metabolism. Next hormone that we are going to see is which is adiponectin, which is a peptide hormone of around 224 amino acid. This sensitizes the other organs to effects of insulin, and this protects against the atherosclerosis, inhibits the inflammatory response, and then the metabolic role. If you see, it increases the fatty acid uptake by the myocyte, and then it increases the rate of beta oxidation, and it blocks the fatty acid synthesis, blocks the glucogenesis, and then it increases the uptake of the glucose and then the catabolism. And this adiponectin triggers the phosphorylation and then the activation of the AMPK pathway. So this is the overall AMPK pathway takes place whenever the long fast starvation is there from the adipose tissue that shrinks and then that releases the adiponectin, and that induces the AMPK pathway. So that leads to the multiple changes in the metabolic pathway. So if you see, the decreased reserves of the triglycerols in adipose tissue triggers the release of the adiponectin, and this inhibits the energy consumption process and stimulate the energy producing process. Adiponectin acts through its receptor in the brain to stimulate the feeding behavior and inhibit the energy and consuming the physical activity to inhibit the thermogenesis in brown fat. And AMPK regulates the specific enzyme in the key metabolic process and then the phosphorylation. Here if you see the AMPK, if it is activated, that increases the glycolysis and then the glucose transport as well as the fatty acid oxidation. Whereas fatty acid synthesis will be inhibited, lipolysis is inhibited, cholesterol synthesis is inhibited, triacylglycerol is inhibited, glycogen synthesis and protein synthesis is inhibited. The same takes place in the other way also. In the heart, if you see, the fatty acid oxidation takes place, glucose uptake and then glycolysis. In skeletal muscle, fatty acid oxidation is promoted and then the glucose uptake is promoted. Whereas in the brain, the feeding behavior takes place, whereas the energy expenditure is inhibited. So other things also takes place here. There is one more hormone or the protein that we talk about is resistin. This usually discovered in 2001 in mice, and this induces the insulin resistance. So it usually belongs to the family of resistin-like molecules with the different expression patterns and then the effects. This usually found in the adipose tissue, bone marrow, lung, placental tissue, pancreatic islets cells, and then the plasma. In obese patient, if you see, there is an increase in the resistin levels, particularly in the individuals with excess visceral adiposity. This resistance has been shown to contribute to the insulin resistance, a hallmark feature of the metabolic syndrome, and then the type 2 diabetes. And if you see, the resistance has been implicated in the regulation of the adipocyte differentiation and lipid metabolism, and potentially influencing the development of obesity. It is also involved in the inflammation, immune responses, and promoting the release of the pro-inflammatory cytokines. And there are other proteins which are related to this body mass maintenance. There is such proteins called peroxisome proliferator activity receptors. There are certain ligands present in the body whenever we take any kind of food. That ligand can be the cholesterol molecule, free fatty acids, or the free fatty acid derivatives that activate the certain kind of proteins called PPAR, that is nothing but peroxisome proliferator activator receptors, and that in cytosol it again binds with the RXR protein that forms a heterodrimer. Then it goes inside the nucleus of the host, and there it will increase the certain gene expression, and that is leads to the uh, the genes responsible for the lipogenesis as well as the lipolysis takes place. There are three PPAR people have seen, that is PPAR gamma, PPAR delta, as well as PPAR alpha. What happens? The first one is the PPAR gamma. So that usually expressed primarily in the liver as well as in the adipose tissue. And this activates the genes responsible for the differentiation of the fibroblast into adipose tissue, and it's encode the proteins required for the lipid biosynthesis as well as the storage in the adipose tissue. And PPAR gamma is activated by the thiazolidinodione drugs that are used to treat the type 2 diabetes mellitus, because that will reduce the lipid synthesis as well as the storage in the adipocytes. The next one is the PPAR alpha that is expressed in the liver, kidney, heart, skeletal muscle as well as in the brown adipose tissue. The ligands for this PPAR alpha is eicosanoids and then the free fatty acids. Fibrates such as the phenofibrate as well as the ciprofibrate, this usually used in the treat the coronary heart disease by raising the HDL levels, lowering the blood triacylglycerol. This PPAR alpha turns on the genes necessary for the uptake as well as the beta oxidation of the fatty acids and formation of the ketone bodies during the fasting condition. The last one is PPAR delta. This is a key regulator of the fat oxidation. senses and changes in the dietary lipid. And then PPAR delta acts in liver, muscle, organs, and transcription of the at least 9 genes encoding the proteins for the beta oxidation that are regulated by the PPAR delta, and for energy dissipation through the uncoupling as the mitochondria. So this causes the fat depletion, weight loss, as well as the thermogenesis. So there is such thing called lipid burden hypothesis. Whenever in our body more lipid is there, so that leads to the in adipocytes, normally the synthesis and then the storage of triglycerol that is insulin sensitive as well as the produce leptin in this case. In the obese individuals, the adipocytes overfilled that is less sensitive to the insulin, that is nothing but called insulin resistance. And gene expression of the development of the new adipocyte, that is genes for the transcription factors of SREBP1 and PPAR delta is downregulated in the adipocytes of the obese individuals, but it is upregulated in the other tissues including the skeletal muscle as well as in the liver. So the ectopic lipid droplets takes place here, and that excess stored fatty acids and then the triglycerols are toxic to the liver as well as in the muscle, which is susceptible to the individuals. And here, when the insulin resistant comes, the changes in the activities of the signaling enzymes and then the transcription factor takes place, and then the adiponectin synthesis in the adipocytes, and then the adiponectin level in the blood decrease with obesity, and then the increase with the weight loss. And chronic inflammation of the adipose tissue is a common feature of the obesity. Genes associated with the inflammation and macrophage activity are upregulated, and macrophage invasion of the adipose tissue takes place. And then lipid laden adipose tissues, lipoapoptosis, triggered by the abnormal concentration of the lipids takes place. And previously, all obese people they thought that they are unhealthy, but recent guidelines says that there are two different types of obese people, that is metabolically healthy obese as well as the metabolically unhealthy obese. Metabolically healthy obesity patients are they are having the defined BMI rate, insulin sensitivity, and systematic inflammation, and subcutaneous white adipose tissues increased, and then the intra-abdominal white adipose tissues are normal. Whereas adipokines in this case, reduced adiponectin, increased leptin, increased resistin, and then omnitin, and then the FGF21, and then the cytokines are in the normal level. In the other case, in the metabolically unhealthy obesity, the increased adipocyte BMI takes place, and then the low insulin sensitivity or the insulin resistance, systematic inflammation, and subcutaneous fat is increased and intra-abdominal fat is increased, and then the all fat related in the muscles are increased, so that leads to the insulin resistance and then the type 2 diabetes mellitus, and that also leads to the coronary artery disease as well. So the next molecular mechanism that we are going to see, that is alcohol metabolism. Alcohol metabolism is depends on the way that is taken. In stomach, the very the small percentage of the alcohol is taken place, which is consumed, and then the responsible here is the gastric mucosa. The small intestine as well as involved here. That is the majority of the alcohol is taken up by the small intestine, and then the intestinal mucosa are responsible for this kind of thing. The rate and the extent of the alcohol absorption can be determined on the basis of the concentration of the alcohol consumed, presence of the food in the stomach, and then the type of the alcohol beverage, and individual factors such as age, gender, body weight, as well as the metabolism. The distribution, if you see, the distribution usually takes place through blood, and the peak blood alcohol concentration is seen in 30 to 90 minutes after the consumption, depending on the various factors. The high water solubility of this alcohol that makes the alcohol freely diffuse across the cell membranes and distribute into the all body tissues with a high water content. The multiple organs are involved here, that is brain, liver, heart, kidneys, lung, skeletal muscles, as well. Alcohol can easily cross the blood-brain barrier due to its small molecular size and lipophilic properties. And the distribution factors, that is blood flow to the different organs, concentration of alcohol in the blood, the rate of the alcohol metabolism. The alcohol metabolism primarily occurs in the liver, and then the rate of the clearance. The metabolism, if you see, whenever the ethanol takes place by the action of the alcohol dehydrogenase, by the oxidation of this molecule that will be converted to acetaldehyde. And acetaldehyde, again by the action of the acetaldehyde dehydrogenase, there one more NAD plus is used, then finally the acetate molecule will be formed. So the major route of the ethanol metabolism is in the liver, whereas in the liver alcohol dehydrogenase is present in the cytosol that we have to see, whereas this aldehyde is in the mitochondria. So the acetate, if you see, which is a non-toxic in the body, whenever this activity to the acetyl-CoA in the liver, that is ACS1, that is acetyl-CoA synthetase, which is an energy-consuming process that generates acetyl-CoA for the cytosolic pathways and of the cholesterol and fatty acid synthesis. Most of the acetate through circulation enters the skeletal muscle and other tissues get converted to the acetyl-CoA. Whereas in heart and skeletal muscle, that is ACS2 will be there, that in the mitochondrial matrix that converts this acetate to the acetyl-CoA in the body. So therefore generates the acetyl-CoA that can directly enter the TCA cycle and be oxidized to carbon dioxide. There are multiple classes of the alcohol dehydrogenase in the body. Majorly, this class 1 alcohol dehydrogenase are specific for this ethanol metabolism. And the second one is the aldehyde dehydrogenase. More than 80% of the acetaldehyde oxidation in the human liver is normally catalyzed by this mitochondrial acetaldehyde dehydrogenase, that is ALDH2, which has a high affinity for the acetaldehyde and is highly specific. There is an allelic variant of this ALDH2 people have seen that is greatly decrease the capacity for the acetaldehyde metabolism. And most of the remainder of acetaldehyde oxidation occurs through the cytosolic acetaldehyde dehydrogenase. And there is a very small fraction of this metabolism takes place that is called mixed function oxidase, that is CYP2E1. So there is another mechanism, it's called the detoxification of the alcohol by this thing, and this enzyme is nothing but a member of the cytochrome P450 family, and ethanol can be oxidized in liver microsomes to acetaldehyde by the mixed function oxidase. The electron donors are ethanol here, that is not NAD plus, it's NADPH related reaction. So molecular oxygen also involved. So water molecule is secreted here, and finally the acetaldehyde is formed. And this route accounts for only 10 to 20% of the ethanol oxidation in a moderate drinker. So if you see the effect of this ethanol metabolism in the body, there are multiple ways is there. The first one is the increased NADH, NAD plus ratio will be there. So whatever the pathway related to the NADH metabolism, the production, that will be inhibited in most of the cases. So here the first one is the NADH generated in the cytosol and the mitochondria tends to accumulate. So whatever the here it is happening, the accumulation of this NADH takes place in the mitochondria as well as in the cytosol. This usually interferes in the multiple pathways. The second one is, if you see, this inhibits oxidation of the fatty acids which accumulates in the liver. So here the fatty acid oxidation takes place, but due to the high production of this NADH molecule, that inhibits the fatty acid metabolism, that is including the beta oxidation of the fatty acids. So that will not produce the acetyl-CoA. And third one is the re-esterification of this fatty acid takes place because the oxidation it's not taking place. So what are the fatty acid CoAs there that this increase in NADH that gives the glycerol phosphate, and this in the ER increases the triacyl glycerol synthesis. So there increased esterification takes place, and the triacylglycerols are incorporated into the VLDL. So the ethanol induced hyperlipidemia takes place in the body. And the second one is called fatty liver takes place. The reason is the more fatty acyl glycerol in the liver synthesis as well as the hyperlipidemia that leads to the fat storage in the lipid called in the liver called fatty steatosis. So that leads to the medical condition called fatty liver that we are going to deal with in the upcoming slides. And the adipose tissue lipolysis increased after the ethanol consumption and possibly because of the release of this epinephrine. And there is a ketone body synthesis also takes place due to its inhibition of the TCA cycle. An oxaloacetate whatever it is there in the TC cycle that is shifted to the malate, and that leads to the acetyl-CoA enters the pathway for the ketone body synthesis. Then the increased ketone body takes place, and in the blood the ketone acidosis takes place. Then whatever the pyruvate is formed due to the NADH level high, it will be converted to lactate by the lactate dehydrogenase enzyme. So the high level of lactate takes place in the body, and the lactic acidosis takes place. And in the patient with usually gout, this lactic acidemia, what it should do, that will increase the uh, gout possibility, because the uric acid, whatever it should be excreted through urine, that will be inhibited by the lactate. So that's why the patient with gout are advised not to drink excessive amounts of ethanol. And next one is, usually without any food, people are taking any kind of alcohol multiple times. In those patients, what will happen? The whatever the amino acids are synthesized or the gluconeogenic precursors, that will be converted to pyruvate. But due to the high level of NADH in the body, that will again converted to pyruvate, not to the glucose. So the hypoglycemic usually takes place in the fasting state who has been drinking, and then it is depend on the gluconeogenesis to maintain the blood glucose level. And again the oxaloacetate and the glycerol inhibited from the entry in the gluconeogenesis pathway. And if a person is having food along with ethanol, there what will happen? The ethanol consumption with a meal may result in the transient hyperglycemia that leads to the high NADH as well as the NAD ratio, inhibits the glycolysis at the glycerol 3 phosphate dehydrogenase step. So in this step, the incubation takes place. That's why the transient hypoglycemia takes place whenever a person is having a meal with alcohol. And what are the formed aldehyde? Acetaldehyde is usually toxic in the body. The chronic ethanol abuse may manifest itself in three forms, that is the fatty liver, alcohol-induced hepatitis, and then the cirrhosis. So acetaldehyde usually forms the free radicals as well. That leads to this kind of issue. So acetaldehyde accumulates in the liver and it's released into the blood after a heavy dose of the ethanol, and it is highly reactive and binds covalently to the amino groups, sulfhydryl groups, nucleotides, and phospholipids to form adducts in the liver. So that leads to one of the such skin condition called fatty liver. So the fatty liver per se, if you see liver is the predominant site for the lipid biosynthesis, or the any in a well-fed condition, the de novo biosynthesis of fatty acid, triglyceride biosynthesis, cholesterol biosynthesis, phospholipid biosynthesis, glycolipid biosynthesis, and then the VLDL biosynthesis takes place during the normal well-fed state. But whenever a high level of alcohol consumption is there, this lipid generation will be more, and then the lipid cannot be metabolized in the body. So that leads to the deposition of fats in liver cells. So if you see, normally 3 to 5% of the lipids are present in the hepatocytes. Endogenously biosynthetic lipids are metabolized out as VLDL efficiently. But in the fatty liver case, more than 5% of the lipids are retained in the hepatocytes. That is called steatosis. And fatty liver disease is a reversible condition of liver wherein large vacuoles of lipid accumulates in liver cells. And hepatosteatosis and then the steatohepatitis, that is called progressive inflammation of the liver due to steatosis. The consequence leads to non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, cirrhosis, hepatocellular carcinoma, or at the end of the day, the liver failure takes place. So the metabolic defect leading to the development of the fatty liver, if you see, the imbalance between the endogenous tag formation, that is triglyceride formation, as well as the mobilization from the liver as VADL, and defect in the tag formation. For example, the increased free fatty acid influx that leads to the increased lipolysis in the adipose tissue, uncontrolled diabetes mellitus, as well as the prolonged starvation. In diet, if you take more amount of the high fat or the high carbohydrate diet, that also leads to the fatty liver. And there are defect in the VLDL synthesis also takes place in this issue. For example, the defect in the apoprotein synthesis, whereas the protein synthesis inhibitor, puromycin, ethionine, CCl4, chloroform, lead malnutrition, or leads to the defect in the apoprotein synthesis, such as the VLDL. And then the lipid synthesis, for example, the defect in the lipid phospholipid synthesis, or the defect in the lipoprotein assembly, in the case of the hepatocyte damage, and find the secretory defect in the VLDL, because the VLDL will undergo the post-translation modification such as glycosylation. The increased uric acid inhibits the VLDL secretion. So that also leads to the fatty acid accumulation, or the fat accumulation in the liver, that leads to the fatty liver. Our next topic is the nutritional disorders. So the nutritional disorders may be the obesity that we have seen so far, starvation, and in this lecture that we will see protein energy malnutrition such as the kwashiorkor, marasmus, anorexia nervosa, bulimia nervosa, and then the vitamin. This lectures are not related to the vitamin diseases, so we are not going to see vitamin deficiency related disorders here. So the bulimia nervosa is nothing but which is a eating disorder characterized by the recurrent episode of the binge eating followed by the compensatory behaviors like vomiting, excessive exercise, or the misuse of the laxatives. So individuals of feeling a lack of control over their eating behavior. Bulimia nervosa can have severe physical consequences like dental problems, electrolyte imbalance, gastrointestinal issues, or the esophageal damage. So it also impacts the mental health, leading to the depression, anxiety, and then the low esteem, and then the social isolation. Next one is anorexia nervosa. Anorexia nervosa is usually a eating disorder characterized by the intense fear of gaining weight and a disordered perception of the body image. So this is an example that this usually happens in the female. So whoever in the lean thing, they think that they are fat. So they try to reduce more weight. And this leads to the severe food restriction that they usually limit them taking the more calorie and then avoiding the certain food groups and exhibiting the rigid eating patterns, and this results in the physical as well as the psychological impact. Anorexia nervosa can result in the serious physical consequence like organ damage, hormonal imbalance, electrolyte disturbance, weakened immune system, or the alongside the psychological effects such as depression, anxiety, social withdrawal, perfectionism, or the and obsessive compulsive disorder also takes place. And next is a protein energy malnutrition. This sometimes called as a protein energy undernutrition, that is PEU. It's a form of a malnutrition that is defined as the range of the condition arising from the coincident lack of dietary protein or energy calories in varying proportion. They include three types. One is a protein malnutrition predominant, that is called kwashiorkor, deficiency in the calorie intake, that is a marasmus, and finally the marasmic shocker, that is marked protein deficiency and then the marked caloric insufficiency signs present, and sometimes referred to as the most severe form of the malnutrition. And if you see kwashiorkor, which means the sickness the baby gets when the new baby comes, or the disease of the deposed child, a term from the local language of the Gad tribe, that is the Ghana. So this, if you see the biochemical parameters that is related to this protein malnutrition case, that is a metabolic rate is decreased. So their metabolic rate is decreased, and then the hypoalbuminemia, that is especially in the kwashiorkor, the value will be less than 2 gram per dl, which is a biochemical marker for the kwashiorkor. And then the retinol binding protein also will be very low, and then the IgG increases due to the associated infections, and then the fatty liver may be associated in the kwashiorkor, not in the marasmus case. And this is due to the decreased lipoprotein synthesis as well as the decreased availability of the VLDL. And then the serum free fatty acid is usually high, and then the glucose tolerance is often normal. Hypoglycemia may be seen in the marasmic child, and then the hypokalemia and dehydration may be seen in if there is a diarrhea, and then the hypomagnesemia is also seen in the magnesemia is seen in the patients, and total body water content increases in kwashiorkor up to 60% of the weight. And if you see the difference between the marasmus as well as the kwashiorkor, that is the different parameters that we are going to see. The age onset in the marasmus is less than 1 year, whereas in the kwashiorkor, which is 1 to 5 years. And deficiency, if you say this is a caloric deficiency, whereas this is a protein deficiency. And causes, if you see early weaning as well as the repeated infections or takes place in the case of the marasmus, whereas in the kwashiorkor, starchy diet and after weaning and precipitated by the acute infection. And growth retardation, if you see, the marked growth retardation seen in the marasmus, whereas the growth retardation seen in the kwashiorkor. And attitude, if you see, irritable and then the fretful attitude in marasmus patients, whereas kwashiorkor patients are lethargic and apathetic. And appearance, if you see, like this, shrunken with skin and bones only, and dehydrated patients, and looks glum due to the edema on face. Lower limbs also show the edema. And appetite, if you see, these people are normal, and these people are anorexia. And skin, if you see, the dry and then atrophic skin is seen in the marasmus patients, whereas in kwashiorkor, a crazy permanent dermatitis due to the peeling, cracking, and then the denutrition takes place. And hair, no characteristic change is seen, but here you see sparse, and then the sparse, and then soft and thin hairs are seen, and then the curls may be lost. Associated features, if you see, other nutritional deficiency, watery diarrhea, muscles are weak, and then the atrophic, and then the angular stomatitis is seen in the kwashiorkor, and then the watery area muscles undergo the wasting, and then the crawling and then the walking are delayed. And serum albumin in terms of the marasmus, which is usually the 2 to 3 gram per dl, whereas in the kwashiorkor state, which is less than 2 gram per dl. The serum cortisol will be increased in the marasmus case, whereas in the kwashiorkor cases decreased. And if you see the treatment of this protein energy malnutrition case, usually the dietary intake of protein with protein rich food will reduce the this kind of malnutrition. For example, diets providing the 150 to the 200 calorie kilocalorie per kg body weight, or 3 to 4 gram of protein per kg body weight. A mixture of the three parts of the vegetable proteins, Bengal grams or peanuts, and one part of the milk protein is very effective. The malnourished children tolerate fats very well and may form a major source of the calories in diet up to 30%, and monitored by the disappearance of the edema and rise in the serum albumin level and in the gain in weight. The final topic is they have shown what is the difference between the normal cell metabolism as well as the cancer cell metabolism. If you see in a normal cell, the glucose will be the aerobic glycolysis, and then the anaerobic glycolysis, usually we don't see it. But in the cancerous cells, that is a different cells are in the different metabolism. So people have seen both in the anaerobic as well as the aerobic glycolysis, but predominant of the anaerobic glycolysis leads to the lactate production. Glutamine, if you see, the no addition to the glutamine, but in the cancer cells, the alternative source of the energy is glutamine, and then the fuel for the T-cell cycle. In mitochondrial case, the oxidative phosphorylation takes place. This is not resistant to the ROS accumulation, but whereas in the mitochondria of cancer cells, the oxidative phosphorylation takes place in higher amount, and then the resistant to the reactive oxygen species. And lipid biosynthesis in normal cells, fatty acid synthesis, and then the fatty acid synthesis are antagonistic pathways here. But whereas in lipid biosynthesis, both fatty acid synthesis and then the fatty acid oxidation are activated. So with this, we are getting into the questions of the day. So the first question is, the quantitative unit to measure external Q effect in the metabolic pathways.
External cue.
Yeah,
Is it the response?
yeah, it's a responsive coefficient.
Response.
Elasticity is for
Response.
enzyme, and flex control is for the
Hmm.
overall the pathway.
Yes. Elasticity is for enzyme. Hmm.
Yeah, and responsive coefficient is R. So that is the which of the following is responsible for insulin resistance?
Instant resistance. Uh, is it adiponectin?
No, actually it
No.
is resistant.
No. None of the above.
None of the above actually.
None of the above.
The answer is resistant.
Insulin is resistant. Hmm.
Yeah. And which of the following is responsible for alcohol detoxification?
Alcohol dehydrogenase and aldehyde also.
Yeah,
Hmm.
aldehyde
Both.
dehydrogenase. Not ketone dehydrogenase, not alcohol oxidation.
Hmm.
The final question is, which of the following is not a nutritional disorder?
At AIDS.
Yeah, that is AIDS. Not obesity,
AIDS.
not kwashiorkor, not marasmus, not anorexia nervosa. So it's the
Hmm.
nutritional disorder.